Hi everyone, thanks for listening to my presentations. Today I'll be talking about thyroid gland, and I'll form part 1 of 7, and after that we'll go over many other issues related to the thyroid gland. But for now, let's go over the scope and then move on. The scope will take us through Goiter, Lambert Eaton Myasthenic syndrome, thyroid hormone synthesis, effects of iodine in thyroid hormone synthesis, thyroid hormone actions, normal and abnormal thyroid function test, hypothyroidism, hyperthyroidism, Myxedema, Hashimoto's thyroiditis, Graves' disease, Thyrotoxicosis, thyroid storm, subclinical hypo or subclinical hyperthyroidism. But today, I will go through the brief anatomy of the thyroid gland, because before we'll be able to go through all these different diseases or conditions, we need to know what exactly are we dealing with. Okay, thyroid gland brief anatomy. In a normal adult, thyroid gland weighs 10 to 20 grams. By volume, men have more than women, but the older we become and the bigger we are as per weight, the more the volume. Let me repeat. By volume, men have more volume than women, but the older we become and the bigger our weight, the more will be the volume of the thyroid gland. The volume decreases with increasing iodine. In other words, the volume increases with decreased iodine. Well vascularized, that is, thyroid gland is well vascularized. It is caudal to the larynx, that is, it is below or inferior to the larynx. It is anterior and slightly lateral to trachea. If you check the neck region, the thyroid gland will be found at the anterior portion of the neck region. And the anterior neck, that is the region where we're going to find the thyroid gland, has common carotid artery that is going to supply the superior part of the thyroid. So, common carotid supplies superior thyroid arteries. Thyroid vein will drain into internal jugular vein. We are going to locate the iron bone, and with that, we'll be able to make some landmarks. Because thyroid cartilage is inferior, that is, it is caudal or below the iron bone. Cricoid cartilage is inferior or caudal to thyroid cartilage. Why the main gland we're concerned about, the thyroid gland, is inferior to cricoid cartilage. Cricothyroid muscle will connect the thyroid cartilage to cricoid cartilage. And you can find all this just below the Adam's apple. I think that will help a bit, right? A separate presentation on the neck anatomy showing the thyroid gland will be presented later on. Thyroid lobes and isthmus. There are two lateral lobes with superior and inferior poles. And the two lateral lobes are not staying completely apart because they are connected by thyroid isthmus. The isthmus is covering between the second and third tracheal rings with a pyramidal lobe. The pyramidal lobe grows superiorly towards the hyoid bone and can harbor a thyroglosal duct cyst. Pyramidal lobe is not found in all human beings. Men mostly will have pyramidal lobes, and it's just in about 55% of all human beings. So it's not in everybody that are going to get pyramidal lobe. It is significant when the surgeon is about to carry out total thyroidectomy, because he or she will make sure that it is taken off, or else you will be leaving behind some thyroid tissue. So when someone is saying, I had total thyroidectomy, if pyramidal lobe is still left down there, then it's not total. Look at candy. Posterior to each lobe is a pyramidal extension of the tubercle or Zuckerkandy, through which recurrent laryngeal nerve traverses posteriorly. Ectopic thyroid tissue. Ectopic thyroid tissue is possible, particularly along the part of thyroglosal duct, and that will present as lingual thyroid. That is found in the base of the tongue. Lateral aberrant thyroid is found in the lateral cervical lymph nodes, mostly indicating metastasis. Blood supply. I've said just a few minutes ago that thyroid gland is well vascularized. Superior thyroid artery is the first branch of external carotid artery below the hyoid bone, and that supplies the superior part of the thyroid gland, like the name depicts, and also supplies 15% of parathyroid gland. As a matter of fact, we cannot complete the homeostasis or discussion about thyroid gland without reference to parathyroid gland. So as we continue through this series, of course, references will be made to parathyroid gland. Inferior thyroid artery is a branch of thyrocervical trunk from the subclavian artery, and that supplies bulk of the structures in the anterior neck right there, supply about 85% of parathyroid gland as well. Then there's a small one called TIA. That is not transient ischemic attack, no. It is thyroidal inner artery. It's found in only 3% of humans. And you could see that some people will get it from aortic arch, others from innominate artery, that is brachiocephalic artery, others from subclavian, and others from internal thoracic artery. So it's not just regular, it's not just fixed kind of a structure in everybody, and even those who will have it, regardless of where it's branched from, is still found in only 3% of humans. Thyroidium inner artery can be enlarged in goiter or hyperthyroid situations. Venous drainage. Superior and middle thyroid veins will drain into internal jugular vein, while the inferior thyroid veins will drain into right and left brachiocephalic veins. Nerve supply. Majorly from the autonomic nervous system. And you know, autonomic nervous system will comprise sympathetic and parasympathetic. The sympathetic nerve supply is from superior, middle, and inferior cervical ganglion of the sympathetic trunk, while the parasympathetic portion will have its source from the vagus nerve. and that will supply the parasympathetic fibers to internal branch of superior laryngeal nerve that is sensory in function, to external branch of the superior laryngeal nerve that is motor in function, and right recurrent laryngeal nerve is slightly above the innominate artery at the level above the subclavian, and that will have both motor and sensory function to the larynx. The left recurrent laryngeal nerve from the left vagus will be at the level of the aortic arch, and the non-recurrent laryngeal nerve is found in just 1% of the entire population. I repeat, the non-recurrent laryngeal nerve is found in just 1% of the entire population. Lymph nodes of the head and neck. This will become necessary when we have pathology affecting the thyroid gland. We want to know what is happening to the lymph nodes in that region, particularly when we are suspicious of malignancy. So we have pre-auricular lymph nodes, post-auricular, occipital or parotid, tonsillar, submental or submandibular, superficial cervical, deep cervical or posterior cervical. Okay, lastly for today, parathyroid glands. Though in very close approximation to the thyroid gland, they, however, function independently of the thyroid gland. Recurrent laryngeal nerve is anterior to the superior parathyroid gland and posterior to the inferior parathyroid gland. I have said this now a few minutes ago that we cannot talk about pathologies affecting thyroid gland without reference to parathyroid glands. And with that, I've come to the end of part 1 of 7 as for thyroid gland today. The next is going to be part 2 of 7, and that will be about thyroid hormone synthesis. I believe very strongly that you'll be interested in knowing how thyroid hormones T3, T4, or recombinant T3 are being synthesized with the aid of iodine or not, and how are they being released into the circulatory system. Have you heard about hypothalamic pituitary thyroid axis? Don't worry. How come that the brain is controlling the pituitary gland, and pituitary gland is controlling the thyroid gland, and then we're having the hormones affecting us positively or negatively? And all these things will come to light in the next few presentations. Thanks for listening. Remember to share and subscribe. I appreciate it.